What did you do? How did you treat phaeochromocytoma? Yes? Surgery? How much? 7.5 centimeters? Pheo? And how did you approach it? Okay. Convert. And do you know the pathology? It's not malignant, because it was inherent. Okay, I'm glad. And did you block the patient before? What did you give? An alpha blocker. Doxorubicin. Okay. So I have to talk about perioperative management. So here, yesterday we visited the hospital. It was a very impressive visit, I have to say. A lot of patients, and in the ED it was very crowded. I think there are 50 referrals per day. I think that's pretty much. Rachel, who guided us around, wasn't very impressed by 50. She thought it was quite normal. In the ward it was also quite busy. And there were a lot of patients that we would have had on ICU, but they were still very well managed on the ward. So, well, impressive and very nice to see. And here we see a very nice meeting with a Malaysian tea and some food. Really good food. And here's Dr. Jesse, and he has been working the whole night on his presentations. This was in the morning at 5 actually, that he was drinking beer and finishing his presentation. Alright, so, but in November 2014 we encountered a female, and she had palpitations, like 24 years old, and she was referred to the cardiologist at the ED, and they did an ultrasound, and she had a left ventricle ejection fraction of 45%, which is pretty low for a 24-year-old female. Elevated troponins, and they did an MRI core. That's what cardiologists apparently do. And they found a normal systolic left ventricle function and no cardiomyopathy or any myocarditis. So they gave her a little bit of visible, and then they said, well, we'll see you back in a year. But then, in February 2016, I think she never revisited the cardiologist. At the middle of the night, she came in with shortness of breath, palpitations. She was vomiting, chest pain, and last summer both parents died of cancer. She has 7 brothers and sisters. So, trauma examination A, B, C. She had a very high, she had a blood pressure of 130 over 100. She had a frequency of 120, and over the heart they didn't hear anything. Abdominal silent, no acute abdomen, and her EMV was max. So they were wondering, they were doing an ECG, and then they saw lateral cardiac infarct. So what was going on here? But in the meanwhile, she was getting worse and worse. Blood gas was very critical and worrisome, and the X-ray showed lung edema. 24-year-old female. In the meanwhile, she was also turning septic. She needed to go to the ICU, where she had multiple organ failure, cardiac asthma, kidney failure, liver function tests. So, in the ICU, she got a non-invasive breathing mask, some nitroglycerin, and furosemide, and the diagnosis was myocarditis. Treatment, empirical antibiotics. Well, if you have a diagnosis and an empirical treatment and you're in ICU, normally your prognosis is not that well, I think. And then somebody said, let's do an abdominal ultrasound. And they found 2 adrenal tumors. And it said, watch out for Phaeochromocytoma and maybe some other adrenal diagnosis. And then they looked back at the MRI of the heart that I told you about initially, and there were 2 large tumors actually. And the radiologist never saw them. Has anybody ever did anybody ever see this movie? I'm not going to show you because if you play movies in PowerPoints at meetings, it always goes wrong, so I never do it. But does anybody know this movie? Who knows it? You know it. What happens? Can you tell? Can somebody give him the microphone? Yeah. So here we see a gorilla, and here we see some people playing basketball.
It's just that they ask you to count how many things, but the gorilla will be walking around and nobody sees the gorilla.
Yeah.
Because you're busy counting.
Yeah, so that's good. I call it the gorilla effect. So you will get this film, so it's pretty tragic because now it will never work for you anymore. But if we would have taken the time, I would have given you the assignment. There's some people playing with a basketball, and you have to count the amount of times they are giving the basketball to each other. And you will focus on the basketball and on those kids doing that. And in the meanwhile, this gorilla walks slowly through the movie, stops halfway, waves, and then walks out. And then all the spectators that you ask afterwards, have you seen the gorilla, will say no. Right? They don't see the gorilla. And it's true, and you don't believe it because I've told you now, but it would have happened to you because it happened to me as well. Right? And this is a gorilla effect. He was looking at the heart, and looking at the heart, but he didn't look at other stuff. And that's not because he's stupid, but it's just because that's what our brain does. You focus on something and you don't see something else. So we did hormonal screening and everything pointed at an extreme of phaeochromocytoma. We did a PET CT and you saw that it might even be a malignant pheo. And then we did a CT scan and we saw the pheo in a very good way. And then of course there was another lesion in the neck. So we did endocrine serum markers, and the patient had a high calcitonin. I told you about that this morning. And then we say 1 + 1 is meant to. So I already told you about the MEN diseases a little bit, so I won't go to the internet now. But she had an MEN disease, and the treatment plan, and now we come to the essence, is that we use preoperative alpha blockers. So she was operated, and we did a big cut. I didn't do the operation, but it was were large tumors, and we were suspicious. We thought there might even be cancers, so we got them out. And this is exactly the one that you saw, the big one, and this is the smaller one that you saw. So this is a picture. Do you know this by Netter? Does anybody have that book? So he draws these beautiful pictures, and he makes one picture, and you can actually see the patient that he draws, and he shows all the symptoms you have for that specific disease. And it's very good for your brain because if you see this female and you think about pheo, you will never forget what the symptoms are for pheo. So if you want to control hypertension before you operate somebody for a pheo, you do it because you want to prevent post-operative morbidity. So that's because I'm saying that now, you have to remind it. Alpha-adrenergic blockade, you give it 2 weeks pre-operatively, that's in our protocol, but you can discuss about that, or beta-adrenergic blockade, 2-3 days pre-operatively, if needed. The physiology is that you are actually regulating the alpha-1 mediated vasoconstriction and the beta-1 mediated tachycardia in entropy. That's actually what you're doing. So usually you give some salt as well, you give pre-operative alpha blockade, and that's recommended at this stage still by most endocrine societies worldwide. That's the topic where I'm going to talk about. So in my hospital, there's a PhD that did a large study, they call it the Prescript study, and they did a randomized control trial looking at phenoxybenzamine versus toxicity. And it was a national trial. A lot of patients were included, and there was a lot of logistics involved. And they were actually asking the question, which alpha blocker was the best? in my opinion, it's quite a big study for a small question about which medication you should use. I think we could have answered a lot of other very interesting questions, but it was already running when I was coming into the set. And the whole idea, but I just told you about it, is to look at doxycycline and phenoxybenzamine, and to look which one would be the best, to compare the efficiency of those two in controlling perioperative hemodynamics in patients undergoing the removal of Phaeochromocytoma. So here you see the algorithm. They had to be older than 18 years, a benign PO, so non-malignancy, and severe hemodynamic instability was an exclusion criterion, and also pregnancy. And they formulated a range. So they said, okay, you have to have an MAP of 60, and you shouldn't have a systolic blood pressure higher than 160 during the study. If you have, then that will be noted as an incident. So the primary endpoint was percentage of intraoperative time outside the predefined blood pressure targets. So they defined the target. If you would go out, then it would be noted as an incident. Sample size 134 patients. Secondary endpoints were maximum and minimum blood pressure, need for other agents, post-operative hypotension, and cardiovascular morbidity. So here you see the results. And what you actually see is that there is little difference, but during the operation, doxycycline was a little bit less effective than its counterpart, where it is blood pressure is concerned. When you look at mean arterial blood pressure, there was actually no difference. And you can wonder whether this is a clinical relevant difference, right? So the percentage of intraoperative time outside the blood pressure target range was not different between doxycycline and phenoxybenzamine. And phenoxybenzamine prevented intraoperative hypertension more effectively, they said. But there was no difference in post-operative hypertension. They both had post-operative hypertension all the time. And there was no difference in cardiovascular morbidity and mortality. And this was a secondary endpoint. But I actually wondered why it is a secondary endpoint, because what these things do is prevent this. So it should be, in my opinion, a primary endpoint. The doubts about the effect. So at this stage, perioperative pharmacological blockades of alpha receptors, the clinical impact of that on that endpoint, I was just telling you, that secondary endpoint has never been proven. So we're blocking patients, but in the meanwhile, the surgery has become much better, anesthesia has become much better, and we're actually not knowing why we are still doing it. We don't want to have a hypertensive crisis during the surgery, but we have never had the good proof. So that's why Martin Walsh, here he is again, and Ruben, his anesthesiologist, performed a study where they looked at two patients, a patient that they blocked and a patient that they didn't block. So in Essen, the Essen group, they don't block patients pre-operative. And some of the patients were already blocked when they were referred. And those patients that they received it were referred, they went on with blocking before the operation. And the other group, they did not block, and they actually compared those two patient groups. The null hypothesis was no significant difference in maximal systolic arterial pressure between patients who received an alpha blocker and that didn't receive alpha blocker. And the data were analyzed as a consecutive case series and following propensity score matching. That means when you do propensity score matching, that you actually make the two groups similar, and you will actually have to throw out a couple of candidates to make the groups exactly similar and make it better to compare. Here you see the algorithm, the inclusion, and eventually here you see the results where there is no blockade and there's alpha blockade. And this is, I think, yes, this is after the propensity mentioned. There is a significant difference, but the question is whether it was clinically relevant. The Essen group uses sodium nitroprusside during their operation. So that was actually the hidden secret, sorry about that. The sodium nitroprusside was connected to one of the lumens that the patient, of the patient, the central venous catheter, and run at a minimum dose. When there was a blood pressure suddenly higher than 160, they individually increased the amount of nitroprusside. And so that requires a very active form of anesthesia where there's a good communication between the surgeon and the anesthesiologist. Nitroprusside is actually a very old medication and it has been used for a long time and is on the WHO list of essential medicine. So, but more importantly, although there was a small difference between the patients that did not get blockage and that did get blockage, there were no cardiovascular complications in the study. And there was also no difference in the incidence of excessive hypertensive episodes. And maximal systolic arterial pressure was not different without the alpha receptor blockade for the whole closed case series. But it was for the subgroup, as I told you. So, but the effect of alpha blockade is that the systolic arterial pressure increased above the 250 was not affected by the alpha blockade. So, if they got it or no, it didn't go above that. But there were hypertensive episodes, especially where with the patient that receives alpha receptor blockade. And that's also my personal experience. The patients in my center are all blocked. And when we remove the Pheo, actually now the most exciting part is when the Pheo is out, because the patient drops and they have very low blood pressures. And the anesthetist now gets nervous only when I already have removed the tumor, but not during the operation. During the operation, they're actually asleep, doing nothing, drinking coffee, reading the paper. And if I remove it, they suddenly get very stressed, and that's because of the blockade. And it can take several weeks to establish a alpha receptor blockade in advance, and it also caused in this study a prolonged postoperative stay. So it does have a price. It gives you longer admissions, deeper hypertension after ligating the vein, and sometimes patients even need noradrenaline for 2 days. So recently, in Amsterdam, they did a pilot, and what they did, almost finished, they invited Ruben, the anesthesiologist, and Ruben trained one of the anesthesiologists in Amsterdam. And I called the surgeon before I went here, and they did the first 5, and they were actually very happy, and the patients were discharged very quickly, didn't have hypertension, and no use of noradrenaline. So, what should we do? I think we should organize a randomized controlled trial, and but that will be ethically quite difficult, because there will be a lot of medical ethical committees that say it's dangerous and it's not allowed to do it. But maybe we can use specialized non-blocking centers like Essen or in the future Amsterdam, and we can take 1 or 2 more that get good training, and then we can compare centers that do block with centers that don't block. And I think that would be the best and maybe safe setup. And the primary incident, I would say, the primary end would be cardiovascular incident, because that's actually why we're given the medication. And what exactly the blood pressure is and in what range is less relevant than the incidents that we're trying to prevent with the medication. So, concluding, Pheos can be diagnosed anywhere in the hospital, even in the ED, as you've seen. Preoperative blockade is under pressure. A blockade also has a price. Patients stay in hospital longer and they are drowsy afterwards and they need noradrenaline. So we are safe during the surgery and we're happy, but for the patient it's not the best treatment. And only symptomatic Pheos could be blocked. And to conclude with, even in the Netherlands, there are still too many centers that do adrenals. We're at this stage having a sort of a political thing to make sure that the centers that only do 3 or 4 Pheos go to the centers where they do all the Pheos, to have that expertise in all, and also to be making it possible that we have top anesthetists that can do these studies. So thank you for your attention.